Okay, so this chapter, section, topic is going to be alterations in hematologic functions, so that means blood. And we're mainly going to talk about anemias, blood cell cancers like your leukemias, lymphomas, multiple myeloma, those things. And then some clotting disorders when you don't have enough platelets or you don't have enough clotting factors. All right, so we'll start with anemia. And what is anemia, I guess, is the first question. And it seems pretty, I think most people kind of think they know what anemia is, and they probably do, but it's an abnormally low number of circulating blood cells, or, and that or is very important, or the level of hemoglobin. So what that means is that if you don't have enough red blood cells, then you can't carry enough oxygen, and so you're going to feel tired and you're going to not have enough energy, that kind of thing. But you might have the right number of red blood cells, but they just aren't completely full of hemoglobin, or the hemoglobin, they wouldn't be full of hemoglobin. And so it doesn't necessarily mean a low number of red blood cells. That certainly can cause it, but it could be that the red blood cells just aren't full, and so of hemoglobin, since hemoglobin is actually what's carrying it. So it's red blood cells or hemoglobin, or it could be both, and that's going to diminish the oxygen carrying capacity. Okay, so what causes it? So blood loss, yeah, if you bleed, you're not going to have as much blood, and so therefore you're not going to have as many red blood cells. So that kind of makes sense. Hemolysis. Now, if you remember, lysis means to cut something, and in the case of red blood cells, you're destroying or you're cutting the red blood cells. So somehow the red blood cells are being destroyed in hemolytic anemias. And then impaired red blood cell production. So that may mean that either you're not producing enough red blood cells, or you are producing red blood cells that just don't have enough hemoglobin in them, something like that. Okay, so what are the effects? Impaired oxygen transport, yep. Reduction in red blood cells, indices, and hemoglobin levels. So there we go. And the funny thing about hemoglobin is that you can measure hemoglobin levels, and that will always be low. Okay, so even though you might have the right number of red blood cells, your hemoglobin levels will always be low in anemia. And that's important because it's carrying the oxygen, and that's the problem. So signs and symptoms associated with the pathologic process that is causing the anemia. If you're bleeding, that's going to be a pathologic process that's causing anemia. If you have nutrient deficiencies, if you have cancer, that is the pathologic process causing that anemia. You can compensate to up to a degree. If you're not making enough red blood cells, all you have to do really is breathe faster, and your heart needs to beat faster to circulate the red blood cells that you have. Okay, so you'll see an increase in cardiac output, increase in ventilation rate. You may increase plasma volume, so thirst, those kinds of things will happen to get more volume in there. Your body is trying to compensate for that lack of blood volume, lack of red blood cells, lack of hemoglobin. All right, so a couple of terms here. I don't get too excited about these terms. That it's necessary from a histology perspective, so you'll see these terms come up a lot, and they're important. But they kind of, and because of what they indicate, that's why they're important. So cytic refers to cell. So microcytic means that the cells are smaller than normal. So your red blood cells, you can see in some of these, that's probably a platelet. I don't see any that I would call necessarily too small, but here's one that's too big, so that's macrocytic. Okay, so that's macrocytic, and usually that comes from like a nutrient deficiency like folic acid or something like that, where it's trying to fill the blood vessel with, it fills the blood vessel with hemoglobin, but they can't divide fast enough, so it just overfills it, and then it divides, and then you end up with a bunch of really large red blood cells. Chromic refers to color, so that's going to give you an indication of hemoglobin content. So how much hemoglobin is in each of these red blood cells? You can see some of these. So if I don't know if there's one we can call normal here, we might be able to call this one down here normal, and you can see that it's nice and well pink in this case. Normally they're kind of red. But you can see that some of these just don't have as much hemoglobin in them, and so they appear more white when you look at them. So the color comes from hemoglobin, and the red color comes from hemoglobin, and so without as much hemoglobin, you're not going to have as much of a red color. So you might see this with something like an iron deficiency. If you don't have enough iron, then you can't make hemoglobin as quickly, and so the red blood cells won't be full. So we can kind of look at all of these. Here are some examples. We're going to go through some of these. But iron deficiency, yeah, you can see the difference in color. Might see some enlarged red blood cells there. Megaloblastic, so this is definitely enlarged, so that's macrocytic. Sickle cell, you have the wrong shape. They're actually shaped like a sickle, which is a curved tool. I don't know. I think the death guy carries one around. You know, the Grim Reaper guy, and so that's where they get their name. And we'll talk about those, and then the normal ones that have that biconcave shape. That's what we call that. All right. So let's start out talking about hemolytic. So we're breaking blood vessels. Why are we breaking blood vessels? What's wrong with them that they break when they shouldn't break? They're supposed to live about 10 days, or they're supposed to live about 3 months, 3 to 4 months. Sorry, I got it mixed up with platelets. But they're supposed to live a few months, 3 to 4 months, and then they will wear down and break. In the case of hemolytic anemia, for whatever reason, they're breaking too soon. Okay, so characterized by retention of iron and other products of hemoglobin destruction. Okay, so something inside them is causing them to be destroyed. Destroyed blood cells release their contents, which then circulate in the blood. So a lot of times you'll see plasma that may turn kind of a reddish color or something like that. So compensatory increase in erythropoiesis. Now remember, when we have our stem cell, then it divides, it produces something called a reticulocyte. Okay, so the reticulocyte is an immature red blood cell. Okay? It's not really ready to go out in the world. It has to lose its nucleus and then become a actual mature red blood cell. So when you take somebody's blood or you look at their blood, you're going to see more reticulocytes present in that the immature red blood cells, which means that, and that's what matters, I guess, means that there's a higher turnover. The body's trying to compensate. It's trying to make more red blood cells, and what's happening is that you see an increase in these reticulocytes, these immature blood cells. Okay, so increase in reticulocytes due to hyperactive bone marrow increasing production of red blood cells. In hemolytic anemia, there's really nothing wrong with the process of making blood cells. Yeah, there's the compensation. It's trying to make more faster, but the red blood cells that are made, presumably, there's nothing wrong with them. So they're normocytic. That means they are the normal size. Normal chromic, which means that they have the normal amount of hemoglobin. There's nothing wrong with the process of making them, in most cases, of hemolytic. All right, so what are the signs and symptoms? The signs and symptoms are the same as for any kind of anemia. Fatigue, dyspnea, so usually that's going to be a more rapid breathing rate, ventilation rate. Tachycardia, the heart's trying to compensate by beating faster, and others depending on whatever's causing it. Okay, so you know, if it comes from like a leukemia or something, you're going to see all the signs and symptoms associated with leukemia. May see an increase in unconjugated bilirubin. Why would you see an increase in unconjugated bilirubin? Well, because bilirubin is the breakdown of heme, which is inside, you know, each of the chains of a hemoglobin molecule. Okay, so you have inside each of those protein chains, the alpha and beta chains, right inside there you have a heme molecule, and that heme is what's turned into bilirubin. Okay, so logically, if we're breaking this, then you're going to have more heme, which means you're going to be making more bilirubin. All right. But it would be hard to detect mild jaundice. All right, so intrinsic, so causes either intrinsic, which means that there's something wrong with the red blood cell, so like a defect in the red blood cell membrane, hemoglobin, there's something wrong with the hemoglobin, or like a mutation like sickle cell or thalassemias. So that can cause a weakened red blood cell overall. Enzyme systems used to make probably one of these types of things, something that's causing that that the blood cell itself to be a little bit more vulnerable to the twisting and turning that it has to do as it goes through those little tiny vessels. Extrinsic means that you've done something to it. Drugs, toxin, well, okay, not you. You didn't, unless you gave yourself a bacteria. Bacteria, trauma, your immune system is somehow destroying them. Something is going on. External, it's not the red blood cell's fault. That there's something else attacking the red blood cells. All right, so most are extravascular, and destruction takes place in the spleen. So that means usually when you have hemolysis or breakdown of these blood cells, sorry, that in the spleen, what happens is you have the vessels just kind of get smaller and smaller and tighter until they just kind of stop being there. And then the red blood cells kind of move out into what we would call extravascular. They're just sort of out here if they make it through. If not, this kind of funneling that happens in these capillaries will destroy the red blood cell as it goes through. So if you have weaker red blood cells, then they'll just sort of pop as they go through, and then they're going to leak their stuff all over the place, and their macrophages and stuff there in the spleen ready to clean all that up, turn the heme to bilirubin, and recycle that iron, all of that stuff. It's all ready to go there. But we call that extravascular because what happens is that it moves into this pulp area of the spleen, and that's where everything is broken down, recycled. Okay, that's where destruction takes place if it's extravascular. If it's intravascular, that means it's actually occurring still within the blood vessel. Okay, and often associated with faulty heart valves. And then if that's the case, then you've got that leaking that's happened inside the vessel. Okay? And if it happens inside the vessel, then you have that buildup of heme, which has just been released into the plasma now. It's sort of floating around in the plasma because the blood cell broke in some vessel somewhere. We're blaming the heart for the most part. But either way, those blood vessels broke, and now they're just kind of in there. So that hemoglobin can bind to plasma proteins. We're talking mainly about bilirubin. And if there's too much, then that free hemoglobin that's floating around will make the plasma turn red. It could make its way into the kidneys, and then the heme, which is red in color, will move into the urine, and then your urine is going to be darker in color. So that's another indicator that it's hemolytic. So types of hemolytic anemia, membrane disorders. So we mentioned that as a possibility. There's something called hereditary spherocytosis, which makes the red blood cell round or spherical instead of donut shaped, or whatever shape you want to call that. Mine looks like a peanut. But either way, it's not shaped in the way that allows the most mobility. The red blood cells with this shape, higher surface area, yeah, but they're also a little bit more twisty and bendy, and they can kind of move through those small vessels. A sphere-shaped one cannot. There are certain acquired hemolytic anemias and hemolytic diseases of the newborn, or hemolytic disease of the newborn, and these are associated with immune. Okay, so that means that your body's immune system is attacking them. Something on that membrane is being attacked, and it's being broken down. So hemoglobinopathies, those are the ones that affect hemoglobin. Okay, so that means that the membrane's fine for the most part, but the hemoglobin is somehow affecting either the shape or the rigidity of it, and that can cause it to break prematurely. So sickle cell disease, thalassemias, actually both of these, okay, you're also not going to have enough hemoglobin carrying capacity, and so you're not going to be able to, or hemoglobin, so you don't have as much oxygen carrying capacity. And then G6PD, which I think stands for Glucose 6-phosphodiesterase, maybe. But that's an enzyme involved in red blood cell membrane production. Okay, so that was that enzymatic one that we were talking about that makes a component of the red blood cell. And if that's not working properly, then you end up with a weakened membrane, and that's a red blood cell that will break more quickly. All right. So we're going to talk first about aplastic anemias. Aplastic means pretty much, it just means that it's non-cancerous. So it's not caused by leukemia or something like that. So it's a primary condition of bone marrow stem cells that results in a reduction of all three lines. So we're talking about it with anemia, but you also will see a decrease in the white blood cells, and you'll see a decrease in platelets. Okay, so onset may be insidious or very acute and severe. So it could either come on slowly or it could come on quickly. Initial presenting symptoms: weakness. So again, our anemia, well, sort of our anemia signs and symptoms: weakness, fatigability, pallor. Okay, so that's from less red blood cells, so that's the pale color. Petechiae, which are little dots that occur, and those are usually from an inability to clot. So that has more to do with the platelets. Same with bruising and bleeding. Okay, so a reduction in platelets can cause these other symptoms in addition to the anemia symptoms. So decreased in number of neutrophils increases susceptibility to infection. So now our white blood cells are contributing as well. So what causes this? Exposure to high doses of radiation. So even though it's not necessarily, and you can see anemia, anemia certainly happens with cancers, blood cancers, but a lot of times doses of radiation, so radiation treatment, can cause this aplastic anemia. It can cause a reduction in the bone marrow's ability to make all of these things. Certain chemicals, toxins, anything that suppresses hematopoiesis. So notice we're saying hematopoiesis, which means all the red blood cells, not just erythropoiesis or thrombopoiesis. Okay, immune system mechanisms associated with many infectious processes, including viral hepatitis, okay, which is affecting your liver, mononucleosis, AIDS. These can all have an effect on your overall ability to produce blood cells. In this case, all of them. Okay, so let's get a little more specific here. There's something called pernicious anemia. Kind of like the name pernicious, but it's a disease, so we shouldn't. So pernicious anemia, which is sometimes called B12. Now just a reduction in B12, if you don't have enough B12 in your diet, that can lead to anemia, because B12 is kind of important for cell division, for DNA replication, okay, which has to happen. And if DNA replication can't happen quickly enough, then red blood cells can't divide quickly enough, okay? And then you don't have as many, which is anemia. So pernicious anemia is, take that one step further. There's this little molecule, it's a protein that's made by certain cells of your stomach, parietal cells. And the thing about B12 is we don't absorb it very easily. Okay? It's not something that your body is necessarily good at absorbing. So it actually has to make a protein called intrinsic factor that will transport and help carry that B12 into your body. Okay, so it helps with absorption. That's what intrinsic factor does. Now, in the case of pernicious anemia, either the intrinsic factor isn't working properly, it isn't working right, it's not doing what it's supposed to be doing, which is to help absorb B12, or you're not making it, or you're not making enough of it. Okay, so that means that you're not absorbing B12. So even though the problem is with the intrinsic factor, the result and how it presents is with a B12 deficiency. Okay, so that's why it's pernicious anemia, and that's why it's different. So in pernicious anemia, intrinsic factor is deficient. It could be autoimmune, antiparietal cell antibodies interfere with production of it. A lot of times, older people will develop pernicious anemia. They'll produce less intrinsic factor, which messes with their ability to absorb B12. Some people have don't make enough for other reasons, and then of course there are autoimmune reasons too. If that's the case, you have to take injections of vitamin B12. You can't just, take vitamin B12 vitamins because, hello, it's not being absorbed anyway. So just taking more won't help you. So you actually have to take an injection to get it right into your body. And I think usually those are about once a month injections. Okay, so overall, so that was pernicious anemia. But overall, just to kind of put it together in a way. The reason we care about B12 is because it's important for the synthesis of DNA. Now, this is another important point here, and that is that it isn't just the synthesis of DNA, it also prevents abnormal fatty acids from being deposited into neuronal lipids like myelin. So now, yeah, synthesis of DNA, we can say, oh, that makes sense. That's anemia because you can't make red blood cells as fast. However, you also aren't able, or you also have maybe destruction or ultimately destruction, but initially lack of function, lower function of neurons. So you have neurological symptoms too. Neurologic symptoms with B12 deficiency, and therefore pernicious anemia as well. So deficiencies are related to its function, impaired cellular maturation and division. Yes, you have difficulty making red blood cells. Predisposes myelin to break down, results in neurologic symptoms associated with this B12 deficiency. So symmetric paresthesia of the feet and fingers, that's that tingling that you get when your foot falls asleep and then wakes up. Loss of vibratory and position sense, spastic ataxia, so neurological symptoms or neurologic symptoms. So it could result from diet because we can't synthesize B12 and it's found in animal products, and actually not really animal products, but technically the bacteria associated with animal products, that's where we get B12 from our diet. So if you're not getting that, then you're going to have a deficiency. So anemia is from deficient red blood cell production. Oh yeah, that's still what we're talking about. Folic acid deficiency. So folic acid kind of does the same thing. It's required for DNA synthesis, right? So if it's required for DNA synthesis, then that's going to have an effect on red blood cell production, maturation. Right, so and if you're asking if it affects other things, division of other things too, yes, we see it first in red blood cells because we make those at a pretty high rate. But we also know that folic acid deficiency can cause spina bifida, which is where that neural tube doesn't close because the cells don't divide fast enough in a developing embryo. Okay, so that embryo is developing, dividing, and it forms that neural tube early on, and then it can't close up. Okay, so this is why it's important to have folic acid for a new mother or pregnant woman would have to have folic acid. Usually, I mean, a lot of times they give folic acid supplements because it's so important in DNA division or DNA synthesis. So it may present similarly to B12 deficiency, but it doesn't have those neurological changes. Okay, or the gastric atrophy. Gastric atrophy, of course, is related to pernicious anemia. All right, so, but mainly keep in mind neurologic changes. That's going to be your big difference between that and pernicious or B12 anemia. So what causes it? Etiologies: inadequate intake, don't take as much, or you drink alcohol instead of having folic acid, which is diet. Elderly people may not get enough. Indigent people who don't have access. Increased demand, pregnancy, infancy, cancer, things that are causing cell division. So pregnancy is, you have a little fetus in there that's dividing, and so you need more folic acid in that case. Infancy, when you're young, you need that cell division. And cancer, you're dividing cells on purpose, or your body is anyway. Folate antagonist chemotherapy, methotrexate. Methotrexate actually blocks folic acid because it's trying to prevent cell division. It's a treatment for cancer and some autoimmune diseases, or not autoimmune diseases, but well, yeah, but yeah, organ rejection, that kind of thing. So malabsorption syndrome, so something like some colitis, if your gut is sick and there's something wrong with it, then you aren't going to be able to absorb it. So all those things kind of make sense. Anemia is from deficient red blood cell production. Yeah, I think I just keep reading that. But iron deficiency anemia. So we've had, let's see, we had B12 deficiency, we had folic acid deficiency, and now iron deficiency. Well, remember at the middle of each of those heme molecules, at the middle sits an iron, and that's where the oxygen binds. If you don't have enough iron, then you're going to not have enough hemoglobin. Okay, so decreased red blood cells, hemoglobin, and hematocrit level. Microcytic, they're smaller. Causes are dietary deficiency, not getting enough iron in your diet, chronic blood loss. Yeah, we'll talk about that when we discuss the iron cycle. Increased demands during growth periods. Okay? If you need more and you don't have it, then you're going to have a deficiency. That just kind of makes sense. So manifestations related to lack of hemoglobin and impaired transport. So some of our same things: fatigability, palpitations. So that's just your cells aren't getting the nutrients they need, so they can't function right. Dyspnea again, angina, especially angina if that's combined with atherosclerosis or something. If your heart is already, the coronary arteries are already trying to get blood to them, and then you put on top of that, you put any kind of anemia. These really apply to any kind of anemia. But if then on top of it struggling to just get a blood supply, you deprive it of oxygen, then your angina is going to kick in more quickly. Tachycardia, and then some other things: brittle, thin, coarsely ridged, and spoon-shaped nails, which is kind of cool, but bad. A red, sore, and painful tongue, which is confusing. I don't know why that happens. Dry, sore corners of the mouth. Okay. So sickle cell disease. It is a chronic hemolytic anemia. This is one that is inherited. Okay, so if we remember our hemoglobin and we remember our subunits that make up the hemoglobin, we have alpha subunits and beta subunits. And just for fun, we're going to put our heme group in the middle of it. We should have made it red. Okay, now we have green blood. We're like Spock. So if we remember that, the alpha and the beta, in sickle cell there's a mutation, a point mutation, changes one little amino acid, but it changes it in the beta subunit, in the beta chain. Okay, so if we're putting the beta, they always put the beta on top, seems like you alpha beta, but it changes the beta subunit or the beta chain. And that will cause the hemoglobin to not function properly, and it forms that elongated shape. And it only forms the elongated shape. So somebody that's just sort of sitting around the house playing video games, or sitting around the house, or sitting in an office, I don't know. But if they're not exerting themselves, I shouldn't be so cynical. If they're not exerting themselves, then they don't show the sickling. It's when they exert themselves that the hemoglobin will, when it's challenged like that, that's when it causes the entire blood cell to change shape. Okay, so when hemoglobin is deoxygenated, the beta chains will link together. Okay, so this beta chain might look up here at the one I drew and say, oh, you look like somebody I want to link together with. I don't know why, it's horrible. But that will happen, and that will then suck that red blood cell down and cause that sickling to take place. And so yeah, it's all because of that beta chain mutation. Okay. So the mechanism, it's autosomal recessive trait. That means that it just doesn't produce the right beta chain. Now, if you have one parent that gives you a perfectly normal gene that works just fine, then you're going to be making beta chains, and you're not going to express sickle cell as much. You'll be considered a carrier in that case. If you only have one copy, you're considered a carrier. You may have symptoms, but the symptoms will be far less severe, okay? Because you're able to make a beta chain using the other DNA. Now, it's a pretty high demand. So red blood cell production is pretty demanding, and so they will have symptoms, but those symptoms will be really only when challenged, when under a heavy exertion or something like that. But however, if both genes are sickle, then most of your red blood cells are going to have that hemoglobin sickle phenotype. So that's what it's called. That's what HBS is, hemoglobin sickle, which means it has the faulty beta chain. And so that means most of them, 80 to 95% of your red blood cells are going to be susceptible to sickling. So the HBS, so that particular, the messed up sickle beta and then your alpha, that is going to be sensitive to that change in oxygen content. And so on exertion or low oxygen, that's what's going to cause the sickling. It's reversible with rest, or if you stop creating that demand. And so the sickle shape leads to clumping, which leads to obstruction of microcirculation and tissue hypoxia, and that's where the symptoms come in, and that's where it gets dangerous. It's initially reversible with oxygenation, like I just said, but if there are repeated episodes, then those red blood cells that are there will become permanently sickled, and then resting won't help as much. Okay? And these cells are fragile and easily destroyed, so that's considered hemolytic. So they will be destroyed, and you're not going to have as many. So that's why also it's an anemia. Okay? Oxygen carrying capacity, and it can be destroyed, hemolytic. Precipitating factors: cold, stress, I've already mentioned, physical exertion, hypoxia in general, dehydration, infection, acidosis, things that are going to cause the sickling. These things all can cause sickling. All right, so remember, fetal hemoglobin has no beta chains. So that means that infants are fine. Okay, so infants are okay, and if the adult, as they grow, if the adult is able to use fetal hemoglobin, turn that gene back on, keep that gene on, and use fetal hemoglobin in place of the beta, then they won't have as much sickling either. Okay, so just kind of a little note there, and also a reminder that gamma chains instead of beta chains are used in a fetus. Okay, so thalassemia. So there are other mutations. We also have genetic mutations in those subunits. Excuse me. Those are called thalassemias. If it's a mutation in the alpha chain, well, we call it alpha thalassemia. And if it's a mutation in the beta chain, we call it beta. And there are a whole bunch of different possible mutations that can cause differing levels of dysfunction. Now, they don't cause the sickling that we saw with sickle cell, but they do affect oxygen carrying capacity. So mutation in gene that directs synthesis of the chains, deficiency in hemoglobin is what happens. Excess production of unaffected chain, so you have excess alpha chain causes insoluble Heinz body, so that's a way to kind of see that, especially with the beta. But you can see it's kind of the same thing. If you affect the beta chain like we saw with sickle, then it's not going to affect the fetus. However, the alpha variant of this will affect fetal. Okay, because the mutation is in the alpha, and then and so it's going to be there no matter what. It's there as an infant. It's there as an adult. The alpha chain is always there. The beta, however, gets turned on later. Okay. All right. So summary. Can kind of look through this. Iron deficiency, megaloblastic, so we talked about B12 deficiency and pernicious anemia, folic acid, aplastic anemias, okay, which is all bone marrow suppression, so red, white, and platelet deficiencies. let's see, chronic inflammation, chronic renal failure can cause these. So we'll talk about that again when we talk about renal failure in general, especially because with renal failure, you're not producing erythropoietin, or you might not produce it because poietin, um, or you might not produce erythropoietin, and so you're not going to give that signal to make red blood cells. So that's something to keep in mind with renal failure, because you see anemia a lot of times, or they could be destroyed also in the glomerulus of the kidney, or they could be lost to the outside in urine. So membrane disorders, we discussed those. Spherocytosis, where it made it round instead of red blood cell shaped. Acquired hemolytic, so this is hemolytic disease of the newborn, which is immune associated, and then we talked about sickle, thalassemias, and then the G6PD deficiency, which is making the red blood cell membrane, which kind of fits into a membrane disorder, but in this case you're not making, it's producing the membrane. All right, so now we're going to talk about some other non-neoplastic white blood cell deficiencies. So we're moving out of anemias, which are red blood cell associated, and moving to non-neoplastic white blood cells. So these are not cancer yet. We haven't gotten to the leukemias yet. Leukopenia. A lot of these are just terminologies that we recognize, and they can happen by a lot of different causes. So your normal white blood cell count is between 4,500 and 10,500 cells per microliters. I don't know why I need not there. So leukopenia, penia usually just means a deficiency in the blood. So leukopenia is a decrease in white blood cell count, okay, in the blood. Includes all white blood cells, but primarily will involve neutrophils, since most of the white blood cells that you make are neutrophils. Okay, so, and I'm gonna skip down that if you have white blood cell deficiency, you're going to have an increased risk of infection. That's a very important concept that hopefully you understand, because white blood cells are our immune system. So neutropenia are specific to neutrophils. Okay. So this the suffix penia is the thing to remember here, because that's what it's indicating. So neutropenia, specific decrease in the number of neutrophils of less than 1,500, and then we can go even further. And we can say, yeah, but what if you just completely don't have any neutrophils? And we call that agranulocytosis. Now, the thing is, what is not having any? It's not zero, it's less than 200. But if you remember, less than 1,500 is a deficiency. Less than 200 is effectively none. So that's where it's agranulocytosis. So it can be caused from, well, the two big ones, either reduced or ineffective production or excessive removal, which can happen through inflammation. Remember, you have inflammation, or you have infection or something, then you're just dumping neutrophils out there. And if you don't have that left shift, if you don't have production of new red blood cells, white blood cells, neutrophils, if you don't have production of new neutrophils, then you're going to use them up. Okay, and reduced or ineffective production, that can happen with cancer, or aplastic anemia. So any of those. So maybe congenital, pathology-induced, or drug-induced. Yeah, there are actually a number of different drugs that one of the side effects is agranulocytosis. All right, so white blood cells deficiency increase the risk of infection. I already mentioned that, and that can cause just a common infection to become fatal. And it says, would you expect to see pus? Well, I would not, because neutrophils are what make up pus. So if you have agranulocytosis, you're not really making neutrophils, so you're not going to have pus, which means also that you're not fighting infection. Okay, so other non-neoplastics, so still non-cancer, but now we're still talking white blood cell. Infectious mononucleosis. Now, I guess the first thing to say about mononucleosis is we already kind of know, just because of the section we're in, that it's affecting white blood cells. Specifically, it infects B cells, which is a white blood cell. It's a lymphocyte. It's a white blood cell. And that's what mononucleosis does. It's usually caused by the Epstein-Barr virus. There are others that can cause it as well. But it's a disease most prevalent in teenagers and young adults. Epstein-Barr is, of course, a member of the herpes family. Evades the immune system, infecting 90% of humans and persisting for life. So Epstein-Barr usually, somehow, somewhere, some form of Epstein-Barr gets all of us and just kind of hangs around in cells. It uploads itself into certain cells and then just kind of hangs around forever. So spreads through oral, in the case of mononucleosis, spreads through oral secretions. That's why it's called the kissing disease a lot of times. So what's it do to B cells? It may kill them and spread as replicated virions. So we would have a decrease in immune function, at least in the sense of what B cells do, production of antibodies and the adaptive acquired immune response. Or it can upload that DNA into the genome of the B cells. That's a retrovirus, and just kind of hang out, become dormant, continue to proliferate at low levels, remains transmissible even if asymptomatic a lot of times. But usually your immune system will get a hold of it. The T cells are able to identify infected B cells and can control it. So cytotoxic T cells, the ones that are always kind of sampling what's inside cells and then killing them if it doesn't look right, yeah, those can get it. The cytotoxic T cells can. So mono onset is gradual, may have a 4 to 8 week incubation period. So incubation periods can be nasty little things, especially if you can spread it at that time. Okay, if it's transmissible during the incubation period, which it can be, because you've got division, and that virus is, as it's destroying B cells, it's sort of putting them out into the blood, and that can make its way to the saliva, which is primarily where it's transmitted. Okay, so treatment is symptomatic and supportive. In other words, there really isn't a cure. You can't give somebody something and say, let's get rid of your mono. All you can do is kind of keep somebody, well hydrated, well fed, and try to relieve the symptoms and let their immune system kind of take care of it on its own. Now, we're going to move to neoplastic disorders. So we're really talking about cancer. Okay, so these have been non-neoplastic. And now, so none of the other things we talked about were cancer. And now we're going to talk about cancers, and specifically, really, we're talking about leukemias and lymphomas, myelomas. So most important blood cell disorders. So there are two origins. We've talked about these different cell lines, the myeloid versus the lymphoid. The myeloid, remember, has some of the granulocytes. The lymphoid are agranulocytes, but are the T and B cells. So we have those different cell lines, and that's important because this is how we characterize and group leukemias. Okay? So myeloid, white blood cells that are formed and differentiate in the bone marrow, includes granulocytes and the macrophages, the monocytes. Monocytes are in the vessel, and then they move out into the tissue area, they become macrophages. And then the other group is the lymphoid. From the lymphoid cell lines, these are T cells, B cells, and natural killer cells. The lymphoid line includes what we're going to identify as lymphomas. Okay, lymphomas are solid tumors that originated in lymphoid structures and lymph nodes or other structures associated with lymph, like red blood or bone marrow. And they're classified as Hodgkin or non-Hodgkin. So we're going to go through all of these. So what causes blood cancers? What causes these leukemias? Largely unknown, specific to the individual type of the leukemia that's involved. Sometimes, there's probably a genetic component. So family history, toxins can lead to it, even if you don't remember being around the toxin, I guess. Radiation, so a lot of times radiation, we use it to treat other types of cancer, and then you end up with leukemia. Okay, so that can do it. And then certain congenital disorders, which kind of comes back to family history. So leukemia, the word leuko means white, and emia means of the blood. So that means white blood, indicating an increase in number of white blood cells in the blood. Malignant neoplasms of cells derived from myeloid or lymphoid. We are already kind of going with that idea that we have the lymphoid line and the myeloid line the other way, and that's how we're categorizing them. So the malignant cell type will overtake other cell types, including red and white blood cells, leading to increased risk of infection and anemia. So that means that just because you have a leukemia that involves one particular cell type, the other cell types are also infected. Okay? So if you have something that's affecting specifically B cells, that a lot of times won't matter. You're still going to spend all of your energy supporting this cancer, not that you want to, but that's what happens, and getting those cells to divide, which leaves less resources, fewer resources to cause red blood cell division. So you're going to also have anemia. You could have clotting disorders, okay? Those kinds of things could come from that. Or you could have, a neutropenia, fewer neutrophils, that kind of thing. All right, so the four types: myeloid, lymphoid, chronic, or acute, and those are listed here, and we'll show that again. So first of all, the difference between chronic and acute, I think we've covered this enough times that we really have an idea, but you'll see with acute, you see a rapid onset. So it's there, and it lets you know it's there, and that's pretty important for leukemia, is that if you get an acute form of leukemia, you feel it pretty quickly, and that actually sends people to get treatment much earlier. Rapid progression, high blast count. So blast counts are blastocysts or fibroblasts. Those are things that are making other cell types or other products, that kind of thing. So they can sort of divide to make, they're kind of like stem cells. But you'll see more of these that are going to kind of produce other things, and that's because your body is trying to replace. It's trying to replace these or it's just producing too many of them. Immature, undeveloped cells. And these a lot of times can replace normal cells. They're not trying to, they just do. So depressed bone marrow function overall can infiltrate various organs, and which we see with Burkitt lymphoma. Anemia, you'll see anemia, so easy bruising, weight loss due to hypermetabolism, bleeding due to low platelets, bone pain due to marrow expansion. Now remember, red blood cells, not red blood cells, well, yeah, those too, but all blood cells are made in the bone marrow. If you turn up the division of even one type of those, then you're producing more and more, and that can cause the bone marrow to expand, and you can feel that. That's going to cause bone pain. Okay, that pushing out. So it can be acute, chronic, insidious, not really noticed, low, slow onset, prolonged, proliferation of more differentiated myeloid or lymphoid cells. So instead of being immature, undeveloped, you'll see that they're a little more differentiated. Often discovered during other tests. So people, a lot of times with these chronic leukemias, don't even know they have it. And really the age at which they get it is later in life. It's like after 65 or 70 is when they go in for another blood test and they say, oh, well, you have this chronic leukemia. And sometimes you may not even treat it. I mean, if it's not causing any symptoms and the person's body is compensating, then treatment may actually cause more harm than good. Okay, so if we go through this and we look at some of these things, so if we start acute, the acute are going to cause the effect more quickly. So acute lymphocytic is 10% of all leukemias. Acute myelocytic is 45% of all leukemias. However, acute lymphocytic leukemia, ALL, is the most common leukemia in children, and that's something to take note of. So most children who get leukemia are going to get the ALL, the acute lymphocytic type. It's less common. You don't see it as much in adults. And it's composed of lymphoblasts, immature B or T cells. Acute myelocytic leukemia, or AML, that is actually the most common, but it's mainly found in adults. It's not, even though children get it, it's the second most common cause of leukemia in children. The actual most children are getting the ALL, and so this you'll see mainly in older adults. Inhibition of myeloid cell differentiation, immature blast cells replace normal cells. So that's what we were talking about earlier. So it's also, so we see myeloid differentiation. Of course, it's myelocytic, so you're going to see myeloid, and over here you're going to see lymphoid. All right, so the chronics. The chronics, really, so chronic lymphocytic, we're talking about lymphocytes, and usually it's B cells when we talk about this. So you can see here 85% of acute are B cells. Chronic is also mostly B cells, clonal malignancy of B lymphocytes. Most common form of leukemia in adults in the Western world. So if an adult gets a leukemia, there's a good chance it's going to be chronic lymphocytic leukemia, CLL. Whereas a child gets it, it's probably going to be acute. All right, so see that distinction. It's mainly older adults, average age of 72 years, rare in people under 40. And there appear to be two forms, highly aggressive or slow progressing. Slow progressing may not even need treatment. Highly aggressive may need treatment. All right, so, and then the last one, the chronic myelocytic, so we're back over here to the myeloid origin. It has something called the Philadelphia chromosome, and that's what makes it kind of special and unique. But 95% of people with chronic myelocytic leukemia, or CML, will have this thing called the Philadelphia chromosome. We'll see what that looks like. It's located on the BCR gene, which I think stands for B cell receptor. Affects hemopoietic progenitor cells. Okay, so that the progenitor cells are, remember earlier in the stem cell line, so they're going to be earlier on. It's not that important, but that's what it affects. But it can affect granulocytes and megakaryocytes. Okay, so that can affect platelet production. Granulocytes are the basophils, mast cells, those guys. And it's about 10%, 10 to 15% of all leukemias, and the average age of diagnosis for this one is 67 years. So again, mainly in older people. So our childhood is going to be the ALL, adults primarily the CLL. Acute is really the most common, but it's not quite as common in children as the ALL. And so that leaves mostly adults who are being affected by the ALL. And yeah, 45, most common leukemia, ALL. And then the CML, the main thing about that is this chromosome abnormality. Okay, so that's mainly who is getting this, the CML. And here's our Philadelphia chromosome. You don't really have to understand all of the processes of this, but what happens is it involves a couple of different chromosomes, and these chromosomes will actually, part of the chromosome will actually move to a different chromosome. Okay, and it involves B cell receptor and the ABL. Let's see, ABL. Can't remember what that means either. L may stand for leukemia, so there's that. But anyway, it's called the Philadelphia chromosome, not because it's shaped like Philadelphia. I don't know why else they would call it that, but it's because it was discovered by two different labs almost simultaneously, and those labs happen to be located in Philadelphia. Okay, so remember, that's associated with CML, or chronic myelocytic leukemia. Okay, so those are the actual soluble blood cancers. Now, we're going to talk about lymphomas. So lymphomas, and the big deal here is they are solid tumors. Okay? Solid tumors of lymphoid tissue. So they vary with respect to molecular features, presentation, and treatment, so they vary. And they are considered the most curable human tumor. Okay, most curable human tumor. There are a couple of classifications. There's non-Hodgkin and Hodgkin. Non-Hodgkin involve B cells, T cells. Hodgkin, mainly B cells. And kind of like the Philadelphia chromosome that was associated with CML, Hodgkin lymphoma show these cells called Reed-Sternberg cells. So a histology or a pathologist can look at the cells of a lymphoma and determine whether it's Hodgkin or non-Hodgkin just by the presence of the Reed-Sternberg cell. And that has an effect on how it's going to spread, how they're going to spread, and the treatment that's involved. So, non-Hodgkin, very widely heterogeneous. They don't all look the same. Most commonly in lymphoid cells with B cell differentiation. So it can be B or T cell, but 85% are going to be B cells. One of the most common cancers, so 4% of all cancers. 1 in 50 chance of getting non-Hodgkin lymphoma. I don't know if I like those odds, but it's better than some other diseases out there, I guess. 3 times more common than Hodgkin. So that's something also to take note of here. Is the non-Hodgkin is more common. Okay, so 3 times more common Hodgkin than non-Hodgkin. Risk factors, it depends on the subtype, gender, ethnicity, chemical or radiation exposure, immune dysfunction. So it depends on a lot of things, but possible origins, Epstein-Barr virus, and that really, we think of Epstein-Barr really for non-Hodgkin when it comes to Burkitt lymphoma, okay, which we'll cover next. But human T-cell lymphotropic virus, HIV, H. pylori has even been implicated in the formation of non-Hodgkin, which H. pylori is stomach ulcers, is where that's famous from. All right, and so here are some characteristics of these lymphomas. Follicular, which means that it's those little follicles where mainly B cells are found. Let's see. Large B cell tend to be aggressive, so maybe nodal, internodal, so it could be the node or between the nodes in the of the follicles. Let's see, mantle cell, less than 10%, rapid progression, less than 1 in 5. So these are just some characteristics. I don't know that these are super important to keep track of. Your main goal here is going to be to separate the non-Hodgkin from the Hodgkin, and kind of figure that stuff out. So here's a Burkitt lymphoma. It is a type, remember this, it is a type of non-Hodgkin lymphoma in children. Okay, it's the most common type in children of non-Hodgkin lymphoma found in children. It's a very fast-growing tumor, infiltrates into the jaw and facial bones, so it can be very painful. Also endemic Burkitt lymphomas are latently infected, all endemic Burkitt lymphomas are latently infected with Epstein-Barr. Okay, so there's our Epstein-Barr coming back to us. Remember, we also saw that in mono, but in this case, somehow it is causing this infection through of the Burkitt lymphoma. We assume it is. Okay, the statement doesn't really say that it's causing it. It's just saying that they are latently infected. So there's a quiet Epstein-Barr that's sort of sitting in there, but there it is. When you find the Burkitt lymphoma, you seem to always find some Epstein-Barr kind of hiding out. So how it causes that or how they're related, not really sure. So clinical manifestation we saw. So we see this with both non-Hodgkin and Hodgkin, but a painless lymphadenopathy. So this is when you see the swollen lymph nodes, then and there is no pain, that may or may not be a cause for concern. This is a big difference here. Doesn't always progress in a predictable fashion. Now, when we're talking about lymph nodes a lot of times are found in chains. Okay, so we see a group of them kind of in a chain, and with non-Hodgkin lymphoma, it doesn't necessarily occur in order. Okay, with Hodgkin lymphoma, it does, but in this case, it could be found. Let's see, maybe found in the mesentery, retroperitoneal, often involves bone marrow. So you don't see that very predictable spreading, which is one of the problems actually, because with Hodgkin, you kind of know that if you found it here, then you can sort of follow its trail, and it might be easier to remove. But in this case, you don't have that guarantee. All right, with non-Hodgkin, you don't have that guarantee. So with more intermediate and aggressive forms, unexplained fever, night sweats, fatigue, unexplained weight loss, itchy reddened patches on the skin. Itchy reddened patches on the skin. Okay, so that's actually, that's something to kind of watch out for, because that's kind of indicative. So diagnosed with lymph node biopsy, so you cut a piece of it out and you look for specific surface markers. Okay, one of those. Okay, so now we're moving, important to understand this, we're moving to Hodgkin lymphoma. One of those markers, or at least something you can see when looking at under a microscope, is the presence of these Reed-Sternberg cells. We don't really know where they come from. So Reed-Sternberg cells are present, but we do know that they are associated with Hodgkin lymphoma. Now, like I mentioned earlier, remember non-Hodgkin, it didn't follow any predictable pattern. Hodgkin arises in a single node or chain of nodes and spreads first to anatomically contiguous lymphoid tissue. So it has a more predictable pattern of spread. Okay, non-Hodgkin is less predictable in terms of location and spread. So kind of important. Also, non-Hodgkin affected people, I believe, under 40, and I think Hodgkin affects 15 to 40 year range and over 55. So there's kind of this area between 40 and 55 where people are less susceptible to it. I'm not sure why. Okay. Okay. I just wanted to. So I'm not sure where I got that 40, but I think it was wrong. Okay, so just remember that right there. This kind of peculiar age range for Hodgkin lymphoma. So manifestations, again, we see the painless lymphadenopathy, usually above the diaphragm is where that's located. So the lymph nodes that are above the diaphragm, so the armpits, neck, that kind of area. Let's see, other symptoms similar to non-Hodgkin that may include chest pain from mediastinum masses. So that's in your middle chest area. All right. The last thing, actually the last cancer we're going to talk about is something called multiple myeloma. It's considered what you would call a plasma cell dyscrasia. All right. And so plasma cell, we're talking about B cells. So B cell origin, single clone of an antibody producing plasma cell. So multiple myeloma, you'll hear about this. There are people that, especially in the news, I hear about it a lot. People who have been diagnosed with multiple myeloma, among other things. But it's about 1% of all cancers. Proliferation in bone marrow. So since it's affecting B cells, and B cells are produced and mature in bone marrow, you'll see an increase in bone marrow pressure, which pushes out on the bone, causing the bone pain. We mentioned that for a lot of these leukemias. But in the case of multiple myeloma, you see bone lesions that may occur. Okay? So bone lesions throughout the skeletal system. Remember that. That's an important characteristic of multiple myeloma. And one of the places that this can take place is in the skull. Okay, so it can affect the skull. It can affect other bones as well, but you do see these little bone lesions. A lot of times they're found in the skull area. Activation of osteoclasts, which are trying to make new bone, that increases bone osteoblasts increase bone. Osteoclasts break it down, so increases bone reabsorption and weakens bone. So you have weakening of the bone, and then you have this pressure, which can cause bone lesions. All right, so proteinuria, you'll see this with a lot of things that. But remember, we're talking about B cells. B cells are producing antibodies. Antibodies are a type of protein. Antibodies are part of those globulin proteins that are found in blood. So you're going to see a whole lot of antibodies in the blood. And those can leak through the liver or the kidney and be found in the urine. Okay? Normal function of bone marrow is affected, decreasing production of other blood cells. All right. So that was our last blood cancer. Now we're going to get to bleeding disorders, clotting disorders. So really, we're talking about decreased platelet levels and decreased clotting factors that are made by the liver. So, thing to remember is that small injuries, microvascular injuries happen quite often. So capillaries will break sometimes with just too much pressure or just bumping yourself. So these happen frequently throughout the body and must be plugged quickly. And when everything is happening properly, they're plugged quickly. However, if for whatever reason you have thrombocytopenia, okay, thrombocytes are platelets, penia means not very much of it in the blood, and so you don't have very many platelets in the blood. So that's a platelet. Thrombocytopenia is a platelet count less than 100,000 microliters, cells per microliter. So spontaneous bleeding can occur when less than 20,000 cells per microliter. And so decreased platelet function in general can be caused by you don't produce enough, you destroy them too many, or they're used up in forming clots. Okay? Either way, you're not getting the function which is clotting. So if you form a bunch of clots and you don't have any platelets left over, then you're going to have a more difficult time forming more clots. So one of these, hemophilia, is an impaired ability to make clots. There's an X-linked recessive disorder of factor VIII. And factor VIII is supposed to form one of the things that it does is it forms a complex with von Willebrand factor to help platelets aggregate. So because it's a faulty factor VIII, then that isn't going to occur in the way that it's supposed to occur, and then you have a defect in the ability to clot. And even though it's intrinsic, the extrinsic turns on the intrinsic, and then they have to work together. And so without factor VIII, you simply are not able to clot properly. Okay, so it depends on how much normal factor VIII is produced. So it depends on. So that's the severity of bleeding depends on how much normal factor VIII is produced. And so what happens with hemophilia from the genetic defect in the factor VIII gene is bleeding in soft tissues, GI tract, joints, places that maybe under have a lot of microvascular or maybe under increased pressure, and there's more potential to bleed. So you would see joint pain, swelling, as well as the risk of just not being able to have surgery because you might bleed out. Okay, just that. Okay, so some other thrombocytopenia disorders. Okay, so that means not enough thrombocytes. Idiopathic thrombocytopenic purpura. Purpura is referring to these spots. Autoimmune disorder. Okay, so I pause on that because that's going to be kind of your clue. It's ITP idiopathic, which really means we don't know where it comes from, but it's autoimmune, resulting in the formation of antibodies against the platelets. So if you're wondering why it's thrombocytopenic, why you don't have enough platelets, it's because you are making antibodies against your platelets, okay, and destroying them. So it leads to excessive destruction of platelets, increasing bleeding. More common in children, usually follows a viral infection. So this is something that can go away. This sounds like a case of the immune system getting confused and attacking something that it wasn't really supposed to. It was supposed to attack a virus, but Instead, those antibodies also started attacking red blood cells. And then there's thrombotic thrombocytopenic purpura. So this is also a combination of thrombocytopenia, not enough platelets, hemolytic anemia, breakdown of red blood cells, and then widespread microvascular occlusion, fever, and neurological abnormalities. So really, what happens is with thrombotic thrombocytopenic purpura is that you use up your platelets by causing clots. Okay, so you end up with fewer clots because you have widespread microvascular occlusion. So that means that you're forming clots all over, and then ultimately you don't have enough platelets to do that, and then you can see some bleeding out. So abrupt onset can be fatal. Anything that's going to cause out of control clotting can be. Multiple etiologies. Inciting event is endothelial damage, okay, and activation of intravascular thrombosis. So you have some kind of endothelial damage to the vessel, and then clotting that occurs in the vessel, okay? And that's going to use up your platelets. Now, there's something else called DIC, disseminated intravascular coagulation, which is kind of similar to TTP, but it's caused by massive activation of coagulation due to production of thrombin and the formation of fibrin. So in this case, we're talking kind of less about platelets. Platelets are obviously going to be involved, but we're talking about turning up and turning on the clotting factors. And so you'll see widespread intravascular coagulation. So we saw that before. So these factors are turned on and being produced, being used up, and then you will see the consumption of these coagulation proteins. So and platelets, okay. And platelets. So what happens is that you have an initial clotting reaction that may happen everywhere. It may lead to you can see down here petechiae and purpura. So that's what starts is you have clotting that happens, bleed through, and then clotting. And then you use up all these coagulation proteins and you use up all these platelets. And then you're not able to form clots anymore. Okay? So the initial symptoms, petechiae, purpura, and then oozing from puncture sites, and then ultimately severe hemorrhage because you've used up your clotting factors and your platelets. It's a secondary disorder. Occurs as a complication of many different disorders. So a lot of times people will come in with trauma and they have so much bleeding in so many areas that they use up their clotting factors and then they're not able to stop any more bleeding. And so any more bleeding can cause them to very, very quickly bleed out. But not only that, but it causes breakthrough bleeding in various places through their body in some of these smaller blood vessels all over their body. And so they'll get these these spots and to the point that they become many centimeters in diameter. Okay, so trauma, postpartum bleeding, cancer, liver disease because that's what's making the factors, so that can cause it, and this can move very quickly, and people can die from this even because it makes it more difficult to get the trauma under control. Okay, so that's it for this topic.